Beta blockers are an important class of medications that must be learned well for both the exam and for clinical years. It's important to know which are selective and which are non-selective. Beta blockers all have the same suffix. They're all going to end in LOL, which is kind of funny if you're below the age of 30 and actually know what that means. So beta blockers can be classified based on their selectivity. Beta 1 selective antagonists, meaning they're more selective for beta 1 more so than beta 2, include all the drugs shown here. So how are you going to remember this for test day? Well, a good way to remember the selectivity of this is beta 1 selective blockers all begin with the letters A through M. So esmolol fits between the letters A through M in the alphabet. Beta 1 receptors are more selective for beta 1 receptors, thus are good for patients with comorbid pulmonary disease because beta 2 blockade leads to bronchoconstriction. Non-selective beta antagonists have equal effects on beta 1 and beta 2. So beta 1 is equal to beta 2. These include propranolol, timolol, nadolol, and pindolol. Most of these drugs have the first letter in the alphabet between the letters N through Z. So N you can think of as non-selective and through Z. And then lastly, what about the drugs that end in LOL but block both alpha and beta receptors? So they're going to be both alpha and beta blockers. Well, these are called the non-selective blockers. These are going to include carvedilol and labetalol. Notice how both the endings don't end in olol, but rather they end in ILOL or ALOL. So that's one of the ways that you can remember the non-selective is they're going to have the non-traditional endings of the OLOL, so they won't have that. These drugs block both the alpha and beta receptors, so that's going to be an important fact to remember here. Let's try our hand at a flash quiz. A 40-year-old female has worsened wheezing after taking propranolol for hypertension. What is the mechanism of her worsened wheezing? I'll give you a second to think about this one. Notice how I keep coming back to our list of different receptors. I've said that if you struggle with these receptors, then you should make note cards on the different receptor types. This will pay off big on test day. Okay, think you got the answer? Non-selective beta blockers prevent vasodilation and limit the effect of asthma medication, like albuterol, that are beta agonists. Even simpler, beta blockers cause bronchoconstriction because beta 2 agonists, or even beta 2 stimulators, cause bronchodilation. Albuterol is an example of a beta 2 stimulator, which is why it is useful in treating asthma, because it bronchodilates. We aren't done yet. I've got another question from you. What is the classification for propranolol? I'll give you some options. Is it beta 1 plus beta 2? Is it alpha plus beta? Or is it a beta 1 selective, meaning it's going to be more beta 1 than beta 2? How would you classify propranolol? This goes back to our discussion on selectivity of the beta blockers. Remember that beta blockers that begin with the letter N through Z are usually non-selective antagonists, meaning they block both the beta 1 and the beta 2 equally. So I would argue that propranolol would be a non-selective beta blocker, so this first option would be correct. Now that we have classified the beta blockers based on their selectivity, now let's take a step back and look at how beta blockers are going to be used clinically. Now, indications for the use of beta blockers include multiple heart and vasculature conditions. First, beta blockers help with angina pectoris because beta blockers decrease heart rate and contractility, which results in a decreased oxygen consumption by cardiac tissue. Now, beta blockers have been shown to decrease the mortality during a myocardial infarction, so beta blockers are used during MIs. Also, beta blockers may be used during SVTs. Now, an SVT simply stands for a supraventricular tachycardia. Ooh, that is a scary word. The supraventricular tachycardia is simply a rapid excitation above the AV node. Here in the diagram, we'll see the normal conduction. Now the SA node is going to initiate an impulse, which it travels down through to the AV node. The signal is then delayed and then sent on to the ventricles. So now there are going to be very many different causes of an SVT, but all of them are going to share the characteristic of sending an impulse too fast down through the AV node. So here we see multiple impulses that are being sent faster than they should down to the ventricles. So now why do beta blockers help with SVT treatments? Now recall from the cardiovascular section that there are many different types of antiarrhythmic agents out there. Class 2 antiarrhythmic agents include certain beta blockers such as metoprolol and esmolol. Class 2 antiarrhythmics decrease or slow the AV node conduction velocity and therefore are useful in treating a supraventricular tachycardia. Also, beta blockers may be used to treat hypertension, since beta blockers decrease cardiac output and also decrease renin secretion. So we need to dust off the old renal section and recall that juxtaglomerular cells, or JG cells, have beta-1 receptors. So these JG cells are going to secrete the renin. When these beta-1 receptors are stimulated, renin is released, and that renin is going to go on to activate the renin-angiotensin-aldosterone system, the RAS system, which is going to increase the blood pressure along with other effects. Thus, by administering a beta blocker, we can decrease the RAS pathway and help decrease hypertension. Then also, beta blockers can be used to treat congestive heart failure, since beta blockers slow the progression to chronic heart failure. And then also, beta blockers can be used to treat glaucoma, for which timolol is effective because it decreases secretion of aqueous humor. Since the use of beta blockers is widespread, it is important to recognize the beta blocker toxicities. Now these are going to include impotence, which is not fun. It's also going to include asthma exacerbations due to the blocked beta-2 receptors. Now, remember our brief discussion earlier about asthma? Beta blockers can cause bronchoconstriction, so be careful when giving beta blockers to patients with asthma. Now, also, adverse cardiovascular side effects are with beta blockers, such as bradycardia, AV nodal block, and also congestive heart failure. And then also, beta blockers have some CNS effects, such as seizures, sedation, and changes in sleep patterns. Furthermore, beta blockers must be used with caution in diabetics because they can worsen blood sugar levels, and they can also blunt the symptoms of hypoglycemia. Alright, you guys are awesome. We're over halfway done with pharmacology at this point. There's a lot of information in this section that will be important on test day. So if you're starting to tire out at this point in the lecture, I really encourage you to stick with me just a little bit longer. Practicing with fatigue will help on test day. So let's do a USMLE scenario. You're 6 hours into your test. You have two 60-minute blocks remaining. That's about 2 more to go, by the way. At this point in the test, you'll start experiencing test fatigue. Now, you'll need to keep your mind sharp for the last 2 sections of the test. This is not the time to relax or get brain mush. Now, what is the best way to prepare for test day scenarios with test questions? Remember, each one of you is a rock star. Let's do this. A 62-year-old man who has been in the hospital for the last 4 days begins decompensating in the middle of the night. When examined, his blood pressure is 60/30, his pulse is 112, and temperature is 40.6, which is pretty high. It's 105 degrees Fahrenheit. His breathing is rapid and shallow, and his arms and legs are warm to the touch. Now, this patient is immediately given a 2-liter bolus of IV fluids, and no resulting change in blood pressure is seen. He's then admitted to the ICU for suspected septic shock. Which of the following drugs should be used initially to stabilize the patient's vital signs? Is it A, clonidine, B, metoprolol, C, norepinephrine, D, phenoxybenzamine, or E, vancomycin? I'll give you a second to think about this. Okay, so looking quickly at the question prompt, we see that the patient is hypotensive. Hypotensive right there. A 2-liter fluid bolus has not helped with this blood pressure. Now, we need to give a drug to treat the low blood pressure. So which drug on this list should be given? Think you got it? If you chose C, norepinephrine, you'd be correct. So let's talk about this quickly. The patient is presenting with hypotension, and now we need a drug that'll increase blood pressure. So how do we do this? I think we should activate alpha-1 receptors on the vascular smooth muscle to cause vasoconstriction. Norepinephrine is an alpha-1 agonist, which will lead to vasoconstriction and thus raise the blood pressure. Clonidine, choice A, is going to be a selective alpha-2 agonist, which is used to treat high blood pressure, not raise blood pressure. So that would be the opposite of what we're wanting to do. Option B, metoprolol, is a selective beta-1 blocker that has chronotropic and inotropic effects. Metoprolol would actually decrease both blood pressure and heart rate, which would make this 62-year-old even worse off. So, not B either. Option D, phenoxybenzamine, is a non-specific alpha antagonist used for pheochromocytomas. Now, we don't want to block the alpha-1 receptors. Instead, we want to activate them. So this drug would not help raise blood pressure either. And then option E, vancomycin, is an antibiotic that doesn't directly affect blood pressure. So best option here is C, norepinephrine. Alright, got another question here. Pay close attention to this question, because this will be a multiple part question just like you may see on test day. A 25-year-old laborer on a fruit farm is brought to the ER by a co-worker because he is having diarrhea and difficulty breathing after his lunch break. His heart rate is 50 beats per minute, his blood pressure is 200/100, his respiratory rate is 23, and his temperature is about normal, at about 36.9. On examination, he is diaphoretic, drooling, and unable to answer any questions coherently. So what should the physician give him to treat his condition? Is it A, dantrolene, B, pralidoxime, C, pyridostigmine, or D, succinylcholine? I'll give you a second to think about this one. And while you're thinking about it, I'm going to circle some things that I find important in this test prompt. Alright, so I circled some of the stuff that should be cluing you in to what the answer is. Now, the correct answer in this option is going to be B, pralidoxime. Does this question look familiar to you? Hopefully it should. I can almost guarantee you will see a question like this on test day. The USMLE loves this concept. So someone who works on a farm comes in with hypertension, bradycardia, and a wet picture of diaphoresis, drooling, diarrhea, confusion. So what is causing all of these symptoms? Aha! Remember I said earlier that insecticides like parathion and malathion can inhibit the enzyme acetylcholinesterase, so our ACHE enzyme, which is going to break down our acetylcholine in the synaptic cleft. Too much acetylcholine causes cholinergic stimulation like diarrhea, meiosis, bronchospasm, sweating, bradycardia, and salivation. So acetylcholinesterase inhibitors are often irreversible for a very short period of time. So it is going to be important to administer pralidoxime, a compound that regenerates our active cholinesterase as soon as possible. So choice A, dantrolene, prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscle. It's going to be useful in the treatment of neuroleptic malignant syndrome and malignant hyperthermia. That's not what we're looking to treat right here. Option C, pyridostigmine, is an anticholinesterase used to treat myasthenia gravis. It would actually make these symptoms worse by increasing the acetylcholine levels in the cleft. And then lastly, we've got succinylcholine here. That's going to be a depolarizing neuromuscular blocker that is used in anesthesiology during intubation. Now, make sure you're comfortable with this question because I can almost guarantee it will show up on test day. Free point. Let's take a look and make this question one step further. Now, pralidoxime is not available in your clinic that you're working at. This patient's symptoms is getting worse, and the clinician, you, need to give him something else to help. What other drug could you give for acute acetylcholinesterase inhibitor poisoning? I covered this drug earlier in this section. Do you know what else you can give him? If pralidoxime is not available, you can give him A. Atropine, a muscarinic antagonist. Atropine is going to block the muscarinic receptors so that the excess acetylcholine won't cause all of these symptoms. So in review, atropine and pralidoxime are the two treatments for acetylcholinesterase inhibitor poisoning. Make sure that you know what the treatment for parathion poisoning is and what the mechanism behind this treatment is. Hopefully it's all going to make sense. Don't worry if you struggled with these questions, since it is not test day. If pharmacology does not come easy to you, then I'd recommend going back over this section while taking notes, or you could try making flashcards over the more difficult sections. Just keep in mind, however, that pure memorization is not the key to pharmacology. Instead, understanding the concepts and small details will fill in time. Take some time for a quick break, and I hope you'll join me in our next section of pharmacology.